One may suspect a chest source of infection if there is radiological evidence, elevated inflammatory markers, and respiratory symptoms. Common organisms include that of Streptococcus pneumoniae as the main gram-positive organism, but also other gram-negative coccobacilli such as Haemophilus influenzae and Moraxella catarrhalis. Beta-lactam antibiotics are effective at covering these organisms, particularly Streptococcus pneumoniae, particularly benzalpenicillin and amoxicillin. Although there's increasing rates of resistance to amoxicillin in Haemophilus influenzae, and neither of these antibiotics are effective against Moraxella. Ceftriaxone, however, will effectively cover all of these common organisms, and thus, in mild community-acquired pneumonia, amoxicillin oral is usually effective, whereas in moderate community-acquired pneumonia, benzalpenicillin is required, and in severe, ceftriaxone is used. If there is concern that this may be a pseudomonal chest infection, tazocin or meropenem can be used as intravenous options in severe infection, and ciprofloxacin would be an oral option in less severe infections. If the patient has a penicillin or beta-lactam allergy, moxifloxacin, a respiratory fluoroquinolone, which, despite being a fluoroquinolone, does not cover Pseudomonas, can be used instead. These are the antibiotics that are used to treat standard pneumonias, or what is sometimes called typical pneumonias. On the other hand, pneumonia can be due to atypical organisms, which cause a syndrome known as an atypical pneumonia. Here, patients present with lower severity symptoms that progress over a longer period of time, such as weeks, as opposed to more severe symptoms progressing over days in the so-called typical pneumonias. Common atypical organisms include Mycoplasma pneumoniae, Legionella, and Chlamydophila species. These organisms are covered by either doxycycline or macrolide antibiotics, which most commonly includes azithromycin or clarithromycin. The main difference between the two is that doxycycline does not cover Legionella and does not cover Mycobacterium avium complex, whereas azithromycin covers these. And so, when a patient is presenting with a severe pneumonia and you want to have the optimum atypical coverage, azithromycin is preferred in combination with ceftriaxone as the treatment for severe pneumonia. However, practically, it is usually obvious if the patient has Mycobacterium avium complex or has Legionella due to the risk factors that are involved, and hence doxycycline along with ceftriaxone is often adequate and azithromycin is not needed. This is particularly important in patients with underlying cardiac disease or structural heart disease, where the QT prolonging effect of azithromycin, and even more so clarithromycin, as well as the numerous CYP3A4 interactions, can become significant, and hence doxycycline may be a safer antibiotic to be used where these factors are relevant. Giving a typical cover along with beta-lactam typical cover is pretty standard practice, in that a mild pneumonia will usually be treated with amoxicillin and doxycycline, a moderate pneumonia will be treated with benzalpenicillin and doxycycline, and a severe pneumonia will be treated with ceftriaxone and azithromycin, with the caveat of deciding between azithromycin and doxycycline, as previously explained. Pneumonias are generally treated for 5 to 7 days, unless they are complicated by a parapneumonic effusion or an empyema, in which case the latter will need a prolonged course of antibiotics, usually several weeks. Patients with underlying structural lung disease, particularly bronchiectasis, may need a prolonged course of treatment. Traditionally, this has been a 2-week course of treatment, although more recent evidence suggests that shorter courses may be just as effective. Sputum culture results can be useful to help guide antibiotic choice in respiratory tract infections, especially if unusual organisms are grown, such as Pseudomonas, which can suggest that the patient has underlying pseudomonal colonization, which may suggest that it is the cause of the infection, although this is not always the case. Or if it grows something like a Haemophilus influenzae, which is shown to produce beta-lactamase, and can therefore guide antibiotic choice in that amoxicillin will likely not be effective, and the patient may need augmentin in this situation, which is one of the few reasons why you would use augmentin to treat a chest source. In general, amoxicillin is adequate and would be more effective than augmentin or amoxicillin and clavulanic acid, in that it can be dosed to achieve higher concentrations. One may suspect the diagnosis of aspiration pneumonia if the patient presents with a clear aspiration event, or has dysphagia or risk factors for aspiration, or has typical radiological findings such as right lower lobe consolidation on chest X-ray or dependent changes on CT. Previously, it was routine to give anaerobic cover for patients with suspected aspiration pneumonia, but we've recently realized that in most cases anaerobic cover is unnecessary, and so in most situations aspiration pneumonia should be covered with just beta-lactam antibiotics, just as you would for a typical community-acquired pneumonia. The only caveat is that patients with very poor dentition may harbor more anaerobes, and thus this may be a significant cause of aspiration pneumonia. Hence, in this situation, anaerobic cover is recommended. For example, with a single agent such as amoxicillin clavulanic acid, which will cover typical pneumonia organisms as well as provide anaerobic cover, or using a combination of a beta-lactam such as amoxicillin with metronidazole, which will cover the anaerobic organisms. One may suspect an intra-abdominal source if the patient presents with abdominal pain and elevated inflammatory markers. Intra-abdominal sources can include things like cholecystitis, cholangitis, necrotizing pancreatitis with overlying infection, gastroenteritis, colitis, diverticulitis, collections, and abscesses. These infections are usually caused by gram-negative anaerobic bacteria, particularly the Enterobacteriaceae species. Therefore, a common antibiotic regimen is known as triple therapy, where ampicillin, gentamicin, and metronidazole are given. The ampicillin covers Enterococcus and some gram-positives, while the aminoglycoside or gentamicin covers essentially all the gram-negatives, while the metronidazole covers the anaerobic bacteria. Alternative regimens include that of ceftriaxone and metronidazole, which will have similar coverage, except that Enterococcus will not be covered when ceftriaxone and metronidazole is given, because Enterococcus is intrinsically resistant to cephalosporins. Or single agents can be given, such as piperacillin tazobactam, which will have good gram-positive, negative, anaerobic, and pseudomonas cover, or intravenous amoxicillin with clavulanic acid, which will have similar cover except it does not cover pseudomonas. Meropenem can be used if an ESBL or an escapum organism is suspected, which we'll discuss a bit later, but ultimately surgery may be required to achieve source control, although recent evidence, particularly in the setting of appendicitis, suggests that intravenous antibiotics may be a reasonable approach or reasonable alternative to surgery. Infectious colitis or gastroenteritis is slightly different in that most patients don't usually need antibiotics for infectious colitis, especially if they are immunocompetent, and if antibiotics are required, regimens are designed to cover common organisms for infectious diarrhea. These include ciprofloxacin and ceftriaxone, and azithromycin, particularly for Campylobacter, as ceftriaxone is generally not adequate to cover Campylobacter. One may suspect a urinary source of infection if the patient presents with urinary symptoms, namely dysuria and urinary frequency, but also abdominal pain such as suprapubic pain and flank pain, as well as fevers and nausea, along with elevated inflammatory markers and often positive leukocytes and sometimes nitrites in blood, on urine dipstick. Urine culture is often positive, and this can often guide antibiotic therapy in terms of the sensitivities. However, urine culture and sensitivities can take up to 24 to 48 hours to get a result, and hence, usually, empiric antibiotics must be prescribed at the time of presentation for a suspected urinary tract infection or urosepsis. For uncomplicated urinary tract infections, or simply UTIs, usually tablet antibiotics can be given. The common sources of urinary tract infections are usually gram-negative Enterobacteriaceae, namely Escherichia coli or E. coli. Other common organisms include Proteus, Klebsiella, and in terms of gram-positive organisms, Enterococcus, particularly in the elderly. Beta-lactam antibiotics, particularly amoxicillin or amoxicillin with clavulanic acid or cefalexin, are options that can be used. However, resistant patterns vary greatly around the world, and so antibiotic choice should be guided by local resistance patterns. For example, where I work, E. coli resistant rates to amoxicillin are around 50%, and so prescribing amoxicillin for a urinary tract infection can be akin to flipping a coin to see whether it will work or not. It may be a risk worth taking in a patient who is relatively antibiotic naive, who's had a first presentation of urinary tract infection that's uncomplicated. But this would be a minority of cases, and in anything that's more severe, or someone who's had recurrent use of antibiotics or recurrent urinary tract infections, usually other options should be looked at, including augmentin. Trimethoprim, along with its combination with sulfamethoxazole known as Bactrim or Alprim, are also effective at treating urinary tract infections due to its high urinary concentration. It's important to note that trimethoprim can block the tubular excretion of creatinine and therefore lead to a transient rise in the creatinine, which should not be misinterpreted as an acute kidney injury. Having said that, Bactrim in itself can cause an acute kidney injury and hypokalemia as well, particularly in combination with other agents that can cause hypokalemia. Nitrofurantoin is a very old antibiotic that has not been used as often as penicillins have in the past, and hence there's a much lower resistance rate to nitrofurantoin in general. However, nitrofurantoin has a very rare but serious side effect of pulmonary fibrosis, and hence most people tend not to use nitrofurantoin first line, although its use is becoming increasingly common. For a complicated urinary tract infection, which includes pyelonephritis, catheter-associated urinary tract infections, or urinary tract infections in males, essentially anything other than cystitis in a non-pregnant female, intravenous empirical antibiotics are often required. The common regimen that is often used is that of gentamicin with ampicillin. This is a great combination because gentamicin covers essentially all the gram-negative organisms, and ampicillin covers Enterococcus faecalis. This regimen is often continued until the sensitivities come back, in which case the antibiotics are adjusted according to the sensitivities. Sensitivities from previous urine cultures can be very useful to guide empirical antibiotic choice, as it gives an idea of what organisms the patient is susceptible to. The main side effect of gentamicin is that of ototoxicity and renal toxicity. However, this generally does not cause issues if only a few doses are given, although the risk and benefits of giving a medication like gentamicin must still be carefully considered prior to prescribing. An alternative empirical regimen would include something like ceftriaxone, but noting that ceftriaxone would not cover Enterococcus, which is somewhat more common in an elderly population, and would also not cover things like Pseudomonas and ESBL. The duration of treatment of uncomplicated urinary tract infections is usually 3 to 5 days, depending on the antibiotic. So trimethoprim is usually 3 days, cefalexin is usually 5 days, whereas complicated infections such as pyelonephritis will usually need longer durations of treatment, around 10 to 14 days of treatment. This is to ensure adequate clearance of the infection at the level of the kidney, and also to cover for potential bacteremia, which is not uncommon in patients with pyelonephritis, where bacteremia is usually treated for a total of 14 days. Another type of urinary tract infection found in males is prostatitis. This can be difficult to diagnose and typically presents with deep pelvic pain or lower back pain, and typically will have a tender prostate on palpation with a digital rectal exam, and may have an elevated prostate-specific antigen or PSA. Mild to moderate acute bacterial prostatitis can be treated with trimethoprim, cefalexin, or ciprofloxacin, which have good urinary and prostate penetration, for a duration of 2 weeks. Severe acute bacterial prostatitis is treated in a similar fashion to pyelonephritis with gentamicin and ampicillin empirically, but often needs up to 4 weeks of treatment that will ultimately be guided by urine culture sensitivities. One may suspect the skin and soft tissue source of infection, such as cellulitis or erysipelas. If the patient presents with erythema of the skin that may be tender, as well as possibly fevers and elevated inflammatory markers. There may be a history of trauma or injury or skin breaks, or an underlying risk factors such as diabetes or venous insufficiency. Skin and soft tissue infections are usually gram-positive organisms, namely Streptococcus pyogenes and Staphylococcus aureus. These two organisms cause sepsis via two different mechanisms and therefore present differently. Staphylococcus aureus produces coagulase, which therefore causes local damage from the site of infection. And so, usually, the rash in Staph aureus cellulitis is usually quite erythematous, can sometimes blister, and is often introduced through a traumatic skin break or wound. This can lead to Staph aureus bacteremia, which can cause seeding and infection virtually anywhere in the body. But prior to bacteremia, there's often an absence of systemic symptoms and a prominence of local damage. In contrast, Streptococcus pyogenes produces pyrogens as part of its virulence, and therefore stimulate an intense inflammatory response, particularly manifesting as fevers. So the classic presentation of streptococcal cellulitis is that of having systemic symptoms and fevers the day before the cellulitis arises. And the cellulitis is often a faint erythema that's not as intense and usually does not blister, unlike that in Staph aureus. The treatment is often beta-lactams, particularly cefazolin, Keflex, or flucloxacillin. If the presentation is more consistent with a Staph aureus presentation, it's probably better to cover Staph aureus specifically with flucloxacillin, although cefazolin or Keflex is a reasonable alternative. Flucloxacillin is associated with a number of side effects, including acute interstitial nephritis, pyroglutamic acidosis, and can also cause irritation of the veins, and therefore prolonged administration of flucloxacillin generally requires a longer or more permanent line, such as a PICC line. In contrast, the side effect profile of cefazolin is generally better. If the presentation is more consistent with streptococcal cellulitis, cefazolin would be the treatment of choice, initially as an intravenous therapy, which can then be switched to cefalexin as oral therapy. Clindamycin can sometimes be used as it covers skin anaerobic bacteria. It can also often work synergistically with beta-lactams in that, given its mechanism of action as a protein synthesis inhibitor, it can reduce the production of virulent proteins, such as coagulase in Staphylococcus aureus, and therefore lead to reduced local damage in Staph aureus cellulitis. However, if the patient has a more resistant organism, such as a methicillin-resistant Staphylococcus aureus or Staphylococcus epidermidis, which is often related to lines, vancomycin therapy is often required. If the patient is extremely unwell and there's concern for either endocarditis or severe skin and soft tissue infection, where the patient has risk factors for MRSA, such as living in a nursing home or having previously grown MRSA or having recurrent hospitalizations, then vancomycin can often be given empirically. Vancomycin also has renal toxicity, and therefore its use must be carefully considered. Some patients with diabetes or venous insufficiency with associated ulcers may be at risk of getting anaerobic organisms as the cause of skin and soft tissue infections. In these situations, anaerobic cover with something like clindamycin along with flucloxacillin or cefalexin or cefazolin, or alternatively something like augmentin, might be useful. A related infection is osteomyelitis, where there's infection of the bone, which usually underlies an area of infection that is more superficial to that area of infected bone. These are often caused by the same skin and soft tissue organisms, and the difference is that they often need much longer, prolonged courses of treatment. A typical uncomplicated cellulitis will usually need about 7 days of treatment, whereas a more refractory or more complicated cellulitis will often end up needing slightly longer courses of treatment in the order of weeks. Patients with osteomyelitis often need very long courses of treatment in the range of at least 6 weeks and sometimes even months, and even lifelong to suppress the infection if surgical resection is not an option, often in cases where metalware that is infected is involved. At this point, I will also mention the most severe form of skin and soft tissue infection, known as necrotizing fasciitis, which should be suspected when there's intense erythema surrounding the skin, which is rapidly progressing and may even have a necrotic or dusky appearance too. When necrotizing fasciitis is suspected, broad-spectrum antibiotics should be given, including meropenem, clindamycin, and vancomycin as well, particularly if they are risk factors. This is primarily to target Streptococcus pyogenes, but also other possible, particularly anaerobic organisms that may be causing the infection. CT imaging of the affected area may be useful in that the finding of gas locules in or between the fascial planes is suggestive of necrotizing fasciitis, although it is ultimately a clinical diagnosis and surgical debridement is often important to achieve source control. Empirical antibiotics should also be used and may require a prolonged course. Now, chest, intra-abdominal, urinary, and skin and soft tissue are essentially the 4 most common sources of infection. So it's good to understand what are the common organisms or likely organisms that can cause these infections and what antibiotics should be used to treat these infections when those are the particular suspected sources. We now talk about more specific infections. Endocarditis is an infection of the heart valves and should be suspected in patients who present with fever without a clear source, or patients who have risk factors for endocarditis, such as intravenous drug use, or even a recently or known diagnosis of a bowel cancer. Streptococcus galolyticus, or previously known as strep bovis, is classically associated with endocarditis associated with a bowel malignancy. And so the finding of this organism or related organisms causing endocarditis should prompt the search for an underlying bowel malignancy as the source of the bacteria. In general, endocarditis is caused by gram-positive organisms, namely Staphylococcus aureus, Streptococcus species, Enterococcus, and sometimes rarer organisms such as the Hayseck organisms, and even things like Coxiella in Q fever. Diagnosis is often confirmed by radiological evidence from an echocardiogram showing vegetations of the heart valve affected, as well as positive blood cultures showing the organism and elevated inflammatory markers, and often high fevers. These are the two major criteria of the Duke criteria, which is used to diagnose endocarditis. The diagnosis can also be made in the presence of one major criteria and 3 minor criteria or 5 minor criteria. Treatment is directed towards the organism, which is often evident in blood culture. For Staph aureus, flucloxacillin is often appropriate, especially if it is a methicillin-sensitive Staphylococcus aureus. If it is a penicillin-sensitive Staphylococcus aureus, benzyl penicillin may be an appropriate option, or even ampicillin. However, if it is a methicillin-resistant Staphylococcus aureus, vancomycin is often required. For Enterococcus endocarditis, synergistic antibiotics is often required, as Enterococcus faecalis and more so faecium can be very resistant. The classic regimen that is used is that of ampicillin with gentamicin. But because the duration of endocarditis treatment is often prolonged, usually 6 weeks, giving a patient with renal impairment 6 weeks of gentamicin is often quite risky and can worsen their renal impairment, and so other synergistic regimens such as ceftriaxone and ampicillin can be used. Treatment of endocarditis is usually 6 weeks. However, recent evidence shows that shorter courses of treatment, as little as 2 weeks, may be effective in highly selected populations with right heart endocarditis without any major complications. Surgery may also be required if there are complications, such as the development of heart failure or if there are very large vegetations, namely more than 2 centimeters in size. One may suspect bacterial meningitis if the patient presents with meningism, fevers, elevated inflammatory markers, and in severe cases, even a non-blanching rash. Common bacterial causes of meningitis include Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, and a less common but important cause of meningitis is that of Listeria monocytogenes, for which patients over the age of 50 or patients particularly who are immunocompromised are at risk of getting Listeria meningitis. Ceftriaxone is an appropriate empirical treatment for bacterial meningitis as it covers all of those common organisms except Listeria, for which if the patient has risk factors for, you would need to add benzyl penicillin to ceftriaxone as your empiric treatment, as benzyl penicillin is required to cover Listeria. Dexamethasone can also be given as adjunct therapy, particularly in cases of Streptococcus pneumoniae, if this is confirmed on cerebrospinal fluid analysis.